Hello students, welcome to this session. Let's study transplant and cancer immunology. Transplantation, transfer of a graft or transplant, the cells, tissues or organ from one side to another. Individual from whom the transplant is taken is referred as donor and to whom it is transplanted is referred as recipient. Classification of transplants based on organ can be kidney, heart, skin graft based on anatomical site of graft. Orthotopic graft when tissue or organ grafts are transplanted to their anatomically normal sites in the recipient. Then such are known as orthotopic grafts. Example, skin grafts. Heterotopic graft are placed in anatomically abnormal sites as when thyroid tissue is transplanted in the subcutaneous pocket. Vital or static transplant, vital grafts, live grafts such as kidney, heart, expected to survive and function physiologically in the recipient. Static grafts, non-living structure like bone, artery, which merely provide a scaffolding on which new tissue is laid by the recipient. Based on genetic relationship between donor and recipient, so the types are autograft, self tissue transferred from one part of body to side to another in same individual, transferring healthy skin to burnt area in burnt patient, use of healthy blood vessel of same person to replace blocked artery, coronary artery. Isograft, syngenic graft tissue transferred between genetically identical individual, monozoic twins. Based on genetic relationship between donor and recipient, the third is the allograft tissue transferred between genetically non-identical member of the same species, kidney or heart transplant. Xenograft tissue transferred between different species, graft of a baboon heart into a man, most commonly used graft in transplant centers. Histocompatibility between graft and recipient decide whether the graft is going to be accepted or rejected. So if they are histocompatible, that means graft is accepted. Example, autograft and isograft. If they are genetically different, antigenically different, then they are rejected. Example, allograft and xenograft. Transplantation antigen, antigens of allografts against which the recipient would mount an immune response. MHC molecules, ABO and RH blood group system. A minor histocompatibility antigen, peptides derived from normal cellular proteins of donated organ. Immune response against MHA molecules is weaker, hence they pose problems of rejection less frequently than MSC molecules. Once one exception is when graft is transferred from male donor to female recipient. Types of graft rejection based on time taken for the rejection, types of immune response mounted against the graft and clinical pathogenic features. Three types: hyperacute, chronic, acute and chronic graft rejection. Hyperacute rejection occurs within minutes or hours of the transplantation, characterized by thrombosis of graft vessels and ischemic necrosis of the graft, mediated by circulating antibodies that are specific for antigens of the graft endothelial cells and that are present before transplantation. Exposure to foreign HLA antigens can occur as consequence of the previous blood transfusion, pregnancy, organ transplantation. Develops antibodies against these antigens. If an individual with these pre-existing antibodies to a foreign HLA antigen receives a graft rejected earlier and more vigorously. Not a common problem in clinical transplantation because it can be avoided by matching the donor and recipient. Potential recipients are tested for antibodies against the prospective donor's blood group antigens by cross-matching an HLA antigen by HLA typing. Second is acute graft rejection occurs within days or weeks after the transplantation due to active immune response of the host stimulated by alloantigen in the graft, mediated by T cells, mainly cytotoxic T cells, occasionally T helper, and antibodies specific to alloantigens in the graft. Cytotoxic T cells directly destroy graft cells, or cytokines secreted by T helper cells induce inflammation which destroy the graft. Antibodies contribute especially to the vascular component of the acute rejection. Antibody-mediated injury to graft vessels by complement activation by the classical pathway. Third is the chronic graft rejection, indolent form of graft damage that occurs over months or years, leading to progressive loss of graft function, manifested as fibrosis of the graft and by gradual narrowing of graft blood vessels called graft arteriosclerosis. T cells that react against graft alloantigens secrete cytokines, stimulate proliferation and activation of fibroblast and vascular smooth muscle cells in the graft. Graft rejection. So this is a summary. First is hyperacute, time taken for rejection minutes to hours. Immune mechanisms involved, preform antibodies, anti-ABO or anti-HLA. Acute weeks to months, mechanism cytotoxic T cell mediated. Chronic months to years, chronic delayed type of hypersensitivity mediated, antibody mediated. Autograft acceptance, when say skin graft is transplanted to the same individual at a different site, revascularization takes place by 3 to 7 days, healing within 7 to 10 days, resolution and acceptance of the graft by 12 to 14 days. Graft acceptance and graft rejection. So pathological sequences that take place when skin graft is placed as an autograft to the same donor, allograft to recipient for the first time, and allograft to the same recipient for the second time. So first set rejection is a type of primary rejection when allograft is placed for the first time from donor to the recipient. And second set rejection, if a recipient that has rejected a graft by first set response, another graft from same donor is transplanted, it will be rejected in an accelerated fashion. Mechanism of graft resection. So graft resection is caused principally by a T cell mediated immune response to alloantigens expressed on the graft cells, primarily MSC molecules. Peptides present in the group of allogenic class 1 MSC molecules derived from proteins synthesized within the allogenic cell. Class 2 MSC molecules are proteins taken up by and processed by the allogenic APC, antigen presenting cells. The process of graft rejection can be divided into two stages: sensitization phase, which involves alloantigen, mainly graft MSC molecules, presentation to recipient's T cells. Effector stage, which immune destruction of the graft takes place due to activation of recipient's T cells. Sensitization phase, T cells in the recipient may recognize donor alloantigens in the graft in two different ways, depending on what cells in graft are displaying these alloantigens to the recipient T cells. Direct pathway, indirect pathway. Effector phase, delayed type hypersensitivity, activated helper T cells differentiate into TTH cells. Cytokines are secreted, activate macrophages which destroy target graft cells by producing lytic enzymes. Cytotoxic T cells, CD8 plus TC cells kill graft cells by recognizing alloantigens, allogenic MSC class 1 molecules. Antibody-mediated mechanism, cytokines produced by T helper cells activate B cells to produce antibodies, mount immune response against graft, mediating hyperacute graft rejection. Acute and chronic rejections minor role. Antibody-mediated destruction of graft by complement-mediated lysis or ADCC. Laboratory tests to determine histocompatibility. Prior to transplantation, various laboratory tests should be carried out to assess the histocompatibility between donor and recipient. So first ABO blood grouping, the RH blood grouping compatibility, blood grouping and cross-matching done, and then HLA typing. So HLA typing, donors antigens expressed on surface of WBCs, leukocytes or their gene to that recipient are matched. HLA compatibility is determined by phenotypic and genotypic methods. So phenotypic method not in use now. Serology, microcytotoxicity, tissue typing, mixed lymphocyte reaction. Genotypic methods widely used. PCR detecting HLA genes, PCR RFLP, restriction fragment length polymorphism. PCR SSOP, that is PPCR, sequence specific oligonucleotide probing. Then PCR SSP, sequence specific primer. PCR DNA sequencing, conformational analysis. Immunosuppressive therapy, hyperacute rejection manifests severely and within minutes, so treatment indicated is immediate removal of the tissue. Chronic rejection generally considered irreversible and poorly available to treatment. Only retransplant generally indicated if feasible. Though inhaled cyclosporine is being investigated to delay or prevent chronic rejection of lung transplant. Acute rejection is treated with therapeutic regimens consisting of one or combination of various immunosuppressive therapies. Graft versus host reaction. So, graft mounts an immune response against the host, that is, recipient, and rejects the host. In contrary to the usual situation of graft rejection, in which the recipient mounts an immune response against the graft antigen. So, GVH reaction occurs when the following three conditions. So, first, graft must contain immunocompetent T cells, that is, stem cells or bone marrow or thymus transplant. Recipient should possess transplantation antigens that are absent in the graft. Recipient may be immunologically suppressed and therefore cannot mount immune response against the graft. Types of graft versus host reaction. Acute or fulminant GVH occurs within 100 days of the post-transplantation. Major challenge in case of bone marrow transplantation. Chronic GVH, less severe form, occurs after 100 days of transplantation. Clinically, acute damage to liver, hepatomegaly, skin rash, mucosa, and intestine diarrhea, mediated grafts immunocompetent T cell. Experimentally, GVH can be produced in mice called run disease. Chronic GVH disease also attacks above organs, but in addition, it causes damage to connective tissue and exocrine glands. Treatment corticoids intravenously. Cancer immunology, tumor antigens of two types, tumor specific transplantation antigen, that is TSTA, and transplantation associated antigen, that is TATA. So tumor specific transplantation antigens, tumor specific antigens are present only on tumor cells and absent in normal cells of the body. May result from mutation in tumor cells that generate altered cellular proteins. Cytolic processing of these proteins would give rise to novel peptides that are presented with class 1 MSC molecules, inducing cell-mediated immune response by tumor-specific cytotoxic T lymphocytes. TSTA are induced on tumor cells either by chemical physical carcinogen or also by viral carcinogen. So, tumor-specific methylcholine and ultraviolet light are examples of chemical physical carcinogens extensively studied, and virus-induced are example Epstein-Barr virus that causes nasopharyngeal carcinoma of several types of lymphoma. Transplantation antigens TATA not unique to tumor cells and may also be expressed by normal cells but very low level. Their level gets exponentially high in tumor cells. So there are two types, oncofetal and non-oncofetal. So oncofetal TATA proteins that are expressed on tumor normal cells during fetal life but not expressed in adult normally. Reactivation of embryonic genes that encode these proteins in tumor cells result in their expression on the fully differentiated tumor cells. Example, alpha-fetoprotein embryonic antigen CEA. Non-oncofetal example, carbohydrate antigen CA125, CA199, prostate specific antigen, and macroglobulin. Tumor markers for diagnosis of cancer. So, oncofetal proteins, alpha-fetoprotein, tumor type is hepatoma, testicular cancer. CEA, carcinoembryonic antigen, gastrointestinal cancer, lung and ovarian cancer. Non-oncofetal secreted tumor antigens, CA125, ovarian cancer, other epithelial cancer, CA199, various carcinoma, prostatic specific antigen, prostate cancer, B2 microglobulin, multiple myeloma, hormones, B subunit of chorionic gonadotropin, hydatidine carcinoma, choriocarcinoma, testicular cancer. Immune response against tumor cells. Both humoral and cell-mediated immune responses are induced by tumor antigens that result in the destruction of the tumor cells. Cell-mediated response appears to play a major role in cytotoxic T cells and NK natural killer cells. Immune evasion by tumor cells. Anti-tumor antibodies produced against tumor antigen may have a role in immune evasion. Blocking factor, anti-tumor antibody may act as a blocking factor. The antibody binds to tumor-specific antigen and masks the antigen from cytotoxic T cells and NK cells. Antigenic modulation. Certain tumor-specific antigens that have observed to disappear from surface of tumor cells in the presence of serum antibodies are then to reappear after disappearance of serum antibody. Masking the immune cells. Circulating tumor antigens may act as a smoke screen, coating the lymphoid cells and preventing them from acting on the tumor cells. Cancer immunotherapy, cytokine therapy involve the removal of immune cells from patient with cancer, either from blood or from tumor. Immune cells specific to tumor will be activated, grown, and returned to the person with cancer, where the immune cells provoke an immune response against the cancer. Cell type that can be used in cancer vaccines include NK cells, cytotoxic T cells, and dendritic cells. Only cell-based therapy currently approved for use in dendritic cells, Provenge, for the treatment of prostate cancer. Regulate and coordinate the behavior of immune system. Example, interferon alpha is used in treatment of hairy cell leukemia, AIDS-related Kaposi sarcoma, follicular lymphoma, chronic myeloid leukemia, and malignant melanoma. Interleukin-2 is used in the treatment of malignant melanoma, renal cell carcinoma. Cancer vaccine, two types, preventive and therapeutic. Preventive, example, HPV and hepatitis B to prevent emergence of cervical and liver cancer respectively. Therapeutic used to treat existing cancer. Research is going for preparation of such vaccine. Vaccines against some oncogenic viruses have proven extremely effective.
Hope you find this session useful for your understanding and for your exams. Thank you.